It's my pleasure to introduce Alan Schwartz. Alan is a long-time faculty member at UIC, but we've only recently had an opportunity to get to collaborate more closely. And in fact, Alan was on Ernest Law's dissertation committee, as some of you may know, and he's helped to contribute to several publications recently with faculty members in the department. And it's a great opportunity, our seminar series, to hear a bit more about some Alan's research and just a bit about Alan's background. He's the Michael Reese Endowed Professor of Medical Education and acting head of the UIC Department of Medical Education and a research professor in the Department of Pediatrics. He's been at UIC since '97, joined the same year as Dr. Walton. Research interests include the psychology of decision-making in patients and by physicians. He's received a lot of awards: the John M. Eisenberg Award for Practical Application of Medical Decision-Making Research, the Ray E. Helfer Award for Innovation in Pediatric Education. So you do a bunch of work in pediatrics, and he's a UIC Distinguished Researcher of the Year, UIC Honors College Fellow of the Year, and he has a lot of UIC teaching awards, including UIC's highest recognition in teaching. Some of you also may know Alan by the way of him being the editor-in-chief at Medical Decision Making and Medical Decision Making Policy and Practice. He's also the director of the Association of Pediatric Program Directors and Longitudinal Educational Assessment Research Network. It's a good thing that we had 5 minutes, but I just wanted to give you a sense that even though Alan's right across the street, he's very accomplished, and please help me in welcoming Alan.
Thank you so much. I just learned that you had my colleague Saul Wiener here last year, and I'm talking about work that I did with him. So hopefully you'll have forgotten everything he said. You'll hear it again from me, or maybe you'll remember what he said and it'll be reinforced. This is a good principle of education, or maybe you'll just hear it in a different way. So that's my, the slides advance. That's my first thing that I wanted to mention, is that everything I'm talking about you can think of as being Saul and I talking about it. Any photos you see, any names you hear are not real patients. And full disclosure, Saul and I have a company that is using some of these techniques in the healthcare market, not in Illinois at the moment, but elsewhere. All right, so we'll start with a story. So this is a story about a patient, a woman, Amelia Garcia, 46 years old, has limited English fluency, is in kidney failure, and has been missing scheduled dialysis appointments. And as a result, she shows up at the ER frequently with high potassium. So in the year that our project began, because these are all based on real patients, she had been there to the ER 5 times that year. And what happens at each ER visit is the doctors, we have great ER doctors here, stabilizer, they get her potassium down, they tell her, you know, you really shouldn't miss your dialysis. We've got the potassium down now, but this is like a potentially fatal thing. You need to be more careful. Please don't miss your dialysis, right? This could be fatal. So, okay, she's home, she's better. On that 5th ER visit, though, something else happened. On the 5th ER visit, there was a medical student working in the ER who said to Ms. Garcia, so why are you missing your dialysis appointments? And she explains, well, I have 2 sons. They both have chronic diseases. One of them, in fact, gets dialysis as well. My son's doctors are here at UIC. I have to bring them here every week for their appointments. My dialysis, because of the way her insurance coverage was, takes place at a clinic that's somewhere else. Not near her house, not near UIC. So what happens when she has to make a choice between taking your kid to be dialyzed here or taking herself to be dialyzed there, she chooses kid, as most people would, right? So the medical student says, well, that's silly, and goes and talks to the attending, and the attending says, yeah, that's silly. Why don't we see if we can move her dialysis here to UIC, and then you could bring your kid in, and we'll take care of you at the same time. And indeed, they worked that out with the insurance company. The dialysis is moved to the UIC clinic. A year goes by, and she hasn't been to the ER. A success story. Maybe, right? A slow success story. So what happened, right? What happened here? That's not a rhetorical question. Why did it take 5 visits? What do you think? Yes. Sorry. I was looking at
maybe nobody asked that question.
Okay, certainly nobody asked that question. Nobody asked her why you missed your appointment. Yeah.
That was my first thought.
All right, the student's voice. I would like to argue that we should expect every physician to be at least as brilliant as that student. So, yeah, well, so doesn't that sound like an obvious thing to ask? Somebody who's missing their appointment. What do you think if you went back and looked at the notes or the charts of Ms. Garcia from those first 4 appointments? What do you think it said?
Patient is non-compliant.
That's exactly what it says. Patient is non-compliant with dialysis, right? Which is, as you all know, healthcare speak for she's not listening to us, and there's nothing we can do about it. Right? In fact, the problem is we're not listening to her. If we understand why she's unable to get her dialysis, then what we call non-compliance, or these days more gently perhaps non-adherence with her healthcare regime becomes understandable, and we can do things about it. Right? So the problem, as Saul and I have framed it, is the failure to appreciate context. That is, what's going on in patients' lives that influences their healthcare. In this case, the context is sort of health related. It happens that what's influencing her life is that her kids have a demand on her that she has to meet, and she's meeting that demand before she takes care of herself. So we call that like conflicting responsibilities. It happens to be a conflicting healthcare responsibility, but need not be. Right? So we think of context as being everything that goes on outside of the patient's skin that's relevant to their care. And when we talk about models of patient-centered decision-making, we've traditionally talked about knowing the clinical state of the patient, right? She's in kidney failure, knowing the research evidence that shows that dialysis is effective for people in kidney failure, knowing patient preferences. Does she want to be dialyzed one way or another? If there's a preference-sensitive choice there. But there hasn't traditionally been a lot of look at the other stuff, right? It's not really a preference, the fact that you have to go get dialysis somewhere else, but it's a circumstance of your life. Right? There's been a little bit of work on social determinants of health, which usually translates to demographic patterns, right, in disease or utilization. But this is not really a demographic pattern. This is something that's pretty specific to one person. It's a pretty individual thing. And nowhere are we ever going to have a set of guidelines for kidney failure that says, perform dialysis, check if the patient can get to their dialysis clinic, or if they have a kid that they need to take care of, and if so, make sure their dialysis clinic is, we're not going to do that, right? That requires some sensitivity, some human sensitivity in terms of expecting that people have different kinds of lives, that we're not all like the average patient in the guidelines, finding out what might be going on, if anything, with this particular patient, and then adapting the plan of care to take that context into account. And sometimes there isn't a contextual issue. Sometimes nothing's going on and it's purely biomedical. Great, that's fine. But when you have somebody who is suddenly missing ER visits, or they're diabetic and their sugars were well controlled for a while and now they're not, right? There are some big cues that maybe something has changed, and maybe it's not just physiological. Ms. Garcia's doctors were great at medical care. They did exactly the right thing. Every time she came into the ER, they kept this woman alive, right? what they weren't so good at was this exploration of life context. So, a contextual error is when a healthcare provider, and I'm mostly talking about physicians, because we mostly study physicians, but later on, when we start talking a little bit about the VA, we're studying teams that include pharmacists, include nurse practitioners, include other healthcare providers. Contextual error occurs when a physician fails to appreciate, to identify and appreciate and use the patient's life context and their treatment planning. So our question, Saul came to me at one point because he'd been trying to explain this to his residents. He'd been seeing them make these kinds of errors, and he's been saying to his residents, no, you need to ask people this, and so on. And he came to me because I was like a methodologist, and he said, how can we figure this out? How can we study that? How can we tell whether physicians make contextual errors? And I'm, by training, a particular kind of methodologist, right? I'm a cognitive psychologist, which means what I was trained to do was try to set up situations that'll screw people up. Okay? Run people through mazes and get them in trouble. So together we said, well, here's what we're going to do. The way to do this is we need to make sure that physicians are seeing patients where they can make a contextual error and where we know what the right answer is. So we began this program that Saul probably talked about of unannounced standardized patients, training professional actors, pretend to be patients, to go in to see physicians, to present a case, and then we'd see what they did because the actor would be carrying a hidden audio recorder. So we'd play back the recordings and we'd find out what happened. Here's one of our archetypal examples, Mr. James, 42-year-old non-smoker, has had asthma since childhood, but it's been well controlled. All of a sudden, it's getting worse. He's got this fancy brand name inhaler, this steroid inhaler that he says was working for a while, but now it seems to be less effective. And by the way, as part of this presentation, he drops a few kind of interesting tidbits. These are a couple of examples of them. He mentions sometimes I wake up wheezing or coughing at night, and he mentions things have been tough since I lost my job. Did Saul talk about this particular case? He was here. People remember it? Some do, some don't. Right? Some do forget. So if you know the case, then you don't have to answer this. But what does sometimes I wake up wheezing or coughing at night mean to you as a healthcare person? Does that trigger any thoughts for you? Yeah. Yeah. Right. So GERD presents a lot like asthma, and it's one of the characteristics of it are it's worse at night. Right? So physicians, when they hear that, if they see that, if you put this case in front of them on paper, they immediately go to, this could be GERD. What does things have been tough since I lost my job make you think of? Yeah.
Maybe lost insurance or less able to afford a branded product.
Okay. Maybe you can't afford the meds anymore. And what do a lot of people do when they can't afford their daily asthma inhaler? Well, they either stop taking it or they stretch it out, right? Maybe I'm not going to take it every day. Maybe I'm going to take it every third day, or maybe when I'm feeling bad, I'm going to take it, right? And I'm in a room full of pharmacists who know that that's not going to be a good thing. All right. So Mr. James drops both of these cues for every physician that sees him, right? He's an actor, and he's got a bunch of other cues too that would suggest that maybe this is GERD rather than asthma, and would suggest that maybe there's a problem with affording the medication. So we listen to the audio recordings, and we find out, what does the physician do? Did they ask other questions that might suggest that they're thinking about GERD, right? That would be smart, given the things that he's saying. Do they ask other questions that suggest that they might be thinking about a financial access problem? It would also be smart, given what he's saying. And in the design of our study, there are 4 different kinds of Mr. James. And the 4 different kinds of Mr. James are different based on what does Mr. James do if the physician asks questions that suggest GERD, or if the physician asks questions that are related to ability to afford the medication. All right, so this is a factorial design. We have the Mr. James in the no-no box. That's the basic problem. If asked about financial issues, Mr. James will deny any problems. I'm on my wife's insurance, no problem getting the prescription filled and so forth. If asked questions about reflux, Mr. James will deny all other symptoms of reflux. So this just looks like exacerbating asthma. The right thing for the physician to do is step up the treatment in accordance with guidelines. On the other hand, Mr. James in the box to the right there, the medically complicated Mr. James, still will say, no, I'm fine financially, but will respond positively when asked about symptoms of reflux. And here, what we think the physician should do is treat the reflux. Bottom left corner is the contextually complicated Mr. James, who will say, yeah, you're right, I can't really afford this every month, so I'm stretching it out. And what we expect the physician to do there is find some way to address that issue, prescribe a lower cost inhaler, find some kind of support program from the pharmaceutical company, whatever it is. And then we've got the Mr. James in the bottom, who we feel very sorry for, who has both reflux and can't afford the meds that he's getting for his asthma, and both of those things need to be considered. Right? If we take these cases, we take these four Mr. James and we put them on paper, and we put them in front of physicians, they get them right 100% of the time. They always know, if you look at the entire script, this is everything that the patient is saying. When you ask them these questions, here are their responses. They immediately say, okay, I'm going to step up asthma therapy, I'm going to treat GERD, I'm going to find this patient a cheaper inhaler, and so forth. That's important to us because we're not really trying to trick anybody here. We want cases that are solvable by a reasonable board-certified internist. And these are. The interesting thing to us is what happens when it's not on paper, right? When a real patient is there presenting in front of the physician. And this is what happens. So when it's the basic problem, you just need to step up asthma therapy. Actually, a quarter of the physicians didn't get that right either. So that's not the problem I'm worried about. That's a problem too. But as you can see, when you move down to the contextual complication row, the error rate, by which I mean physicians writing a plan that is not going to help this patient, go way up. They go up more as you get contextually complicated than they do as you get medically complicated, which is not surprising because the way we train physicians, and indeed most healthcare providers, except perhaps social workers, is to think about the medical. That's what we spend, certainly in medical school, we spend most of their time on the medical stuff. This is a combination of things going on here. Part of what's going on here is, how often did the physicians ask the question that they would need to ask? Like, are you having trouble affording your medication? So Saul likes to say, when he talks about this, there are some physicians who the patient says, I've lost my job, and they say, oh, are you having trouble affording your medication? And those physicians, they get a yes, and they tend to plan correctly. Not all of them. Some of them still don't know what to do about that. But they're much more likely to get it right. There are other physicians who the patient says, I've lost my job, and they say, oh yeah, it's been a really hard economy. Do you have any allergies? Those physicians don't get it right? They're empathic. They're nice people. If you look at scores for patient-centered communication, in many cases they come out higher than the physicians who ask these directed questions. Right? They're nice people, but they get the care wrong because they go on with their checklist or they go on with the next medical thing, and they haven't actually found out what's going on with this patient. So that was the problem that we wanted to find, right? And that we were able in this study to find by setting up cases to find it, right? We thought these are not real hard cases. All of the, on paper they come out fine. We sent them, in this case, there were about 399 visits, so there were about 100 physicians. Each of them got four cases in different variations, and so on. And this kind of error was rampant. And also more costly, as it turns out, than when they made medical errors. The reason why being when you make a contextual error, where you tend to be left in a situation where you're not sure what's wrong. And when you're not sure what's wrong with a patient, what goes on? What do? Yeah, you test them. You test them like crazy. So we have one actor who's coming in with unexplained weight loss. And the contextual variation of that case is his weight loss is because he's not getting enough food to eat, right? if you don't figure that out, you send them for a malignancy workup. So now this person's getting a colonoscopy, and they're getting, all kinds of different cancer exams, they're getting blood tests, and so on, where you could have just found out, oh, they are starving, this person is not getting enough to eat, and we really need to take care of that. Funny story, aside, I took one of my dogs to the vet a few years ago, and the vet noticed that my dog was losing weight, and said, oh, your dog is losing weight, that's not right, I think we should do a workup for cancer. And I said, well, let's think a little bit before we do that, like, has anything changed? And I realized that we had, in fact, changed dog food, but we'd been giving the same amount. We hadn't looked at the calorie difference between the two dog foods. So in fact, our dog was getting fewer calories than before, and that's why he was losing weight. It was exactly the case. And so I said, I'm never going to that vet again. Because he was delighted with the idea of let's do a ton of workup and find out why your dog is, has got cancer, without even thinking about, well, have you changed what you're feeding? How can you not find a contextual error? You will never find, or almost never find, a contextual error by looking at medical records. Why is that? Anyone have a sense of why that might be? Maybe again.
Because there often isn't adequate
Okay, so one problem is we focus the medical record often on the things that we need to document to bill, and social history may not be an important part of being able to bill a visit. That's one possibility. It's actually quite likely. What else? Yes?
I guess the idea of objective versus subjective.
Okay.
So what will actually be on the sheet is more of like the physical. Like, I noticed this, and then if you hear the patient saying, oh, well, I tend to do this, or I tend to drink alcohol every single day, or like for every single meal.
Mm-hmm.
You kind of take that with a grain of salt, because you want to investigate that later, but it looks silly if you put it on a sheet of paper, or for your medical records.
Yeah, so that's also true, and definitely no one ever writes down, I forgot to ask the patient if they could afford their medication, right? Because if you were going to write that down, you would ask the patient. Nobody writes down what they don't think to do. Right? And since these kinds of errors of omission are really important here, we will never see them in the chart. When we looked at the study that we did where we had costed out how much the errors overall would have costed the healthcare system had these been real patients, and we did that quite conservatively. Of the $174,000 of error, we would have detected, by looking at the charts, about $8,800. A little tiny fraction of it, right? Little tiny fraction is chart detectable. Part of that has to do with contextual error. Part of that has to do with the chart in general. One of the other things not related to life context that we have found in the years since, because as I'll talk about in the future, we've done more actor visits than anybody else. We've now done hundreds and hundreds, up to thousands of actor visits, as well as definitely in the thousands of recording actual patient visits. One of the things that we have learned when we listen to the recording of a visit, as opposed to looking at the chart, the notes, is that the chart is highly unreliable. Patients often document things that did not happen in the visit. Physicians document, and physicians often fail to document things that did. So, a recent story about that. Different project. We were helping some practices study diabetes care, and they were looking at the charts from the fake patients that we sent in, and there were a ton of charts that had, normal foot exam, normal foot exam, normal foot exam, normal foot exam. And we were listening to the recordings, and we were talking to the actors, and most of the time they weren't being asked to take off their shoes. You can't do a foot exam at all with someone's shoes on, right? And these actors were trained to portray diabetic patients, and we had taught them what a proper diabetic foot exam was supposed to be like. You're supposed to do a little filament, and there's all these sort of steps to it. So we could just ask them afterwards, did you get a proper diabetic foot exam? But they said no, so we went back and listened to the recording. So that's the problem. So how is it that the chart says normal foot exam when people aren't taking off their shoes? Is it like massive fraud? Probably not. What do you think?
In the clinic I work in, one of the MDs copied the notes from last
Yep.
time.
Yep. That is not just in the clinic you work in, that is widespread, right? Electronic medical records are really about being able to properly bill for visits in this country, right? In other countries, they are different, and what's in them is quite different. But here, it's about, checking the right boxes to be able to bill, and since most visits are supposed to be kind of like the average visit of a particular acuity level, what often happens is there's a template where it's copied and pasted, and you have to affirmatively uncheck the box that says normal foot exam if you didn't do a foot exam. So any of you who study any kind of decision psychology or behavioral economics know about the power of defaults, right? People tend to go with what the default is because it takes effort to change the default. So if the default is normal foot exam, you get a lot of normal foot exams that didn't happen. And that's indeed what we're seeing. The follow-up to that story is we talked to the practices about this, and they said, all right, well, here's what we're going to do from now on. The medical assistant, whenever a diabetic patient comes into the visit, the medical assistant is going to tell them, please take off your shoes and socks and get on the exam table. And now the physician comes in and there's a patient on the table with their bare feet dangling, and they look at the chart and they're diabetic, and they know right away, oh, right, I've got to do something about those feet before I tell them to put their shoes back on. And the rate of documented and actual foot exams went way up. Right? Easy intervention, not about context at all in this case, but about the problem that we have with the validity of medical records and why we can't trust medical records, maybe in general, but certainly for looking at contextual error. The other kind of data that we have a lot of in the healthcare system these days is patient experience of care. If you've ever gone to, certainly UI hospital, but most hospitals or clinics, if you ever go for a visit, a month later you get a survey in the mail from Press Ganey, big company that does this, right? Asking you how was your visit, and they're using typically AHRQ's CAP measures, how would you recommend this doctor to others, and so forth. So, it turns out that when we compare visits where contextual errors are made, visits where they're not made, no difference in patient satisfaction, right, or experience of care. Why not? What's that?
They don't remember by the time the survey comes.
They may not remember. Surveys a month later. Well,
Like you pointed out, a physician or a PA or somebody can be really empathic and personal, but still miss important things that the patient wouldn't necessarily know that they missed.
yeah. How would I know what my physician misses? Right? I don't go to my lawyer and expect to know the law. Right? So yeah, it's a combination of those two things. Right? Patients don't know when most of the time patients don't know when a contextual error has been made because they didn't even realize that was relevant. They were expecting the physician to realize that was relevant. Is that a question or a statement? Yeah.
How much patient expectation affects that too? Like, I don't think that a lot of patients actually, that healthcare providers actually think about those patients.
Yeah, that's a great question. So we could hypothesize, right, based on that maybe there's something we could do to empower patients to make it more likely that they will bring these things up, that they'll talk about them. And we actually just finished a study in the VA where we were giving patients a pre-visit checklist that asked them about a bunch of different domains of potential life context. Are any of these things going on that might be relevant to your healthcare? And they would, it was like in the patient portal, if they said yes, then we asked them for details, and then their physician was going to get a copy of that sheet saying what they were, and the idea was this would help prompt the physician to ask about those things, and it would reduce contextual error. Didn't work. Didn't work for many reasons, I think. Part of it was, first, the physician would get the sheet, and they would just put it down, and they'd never look at it again. That was one big reason why it didn't work. And then even when we tried to really tell them, hey, look at this sheet, there was a disconnect between, all right, I'm supposed to look at the sheet, all right, I'm supposed to look at the computer, all right, I'm supposed to look at the patient, and it became very difficult for them to even incorporate these things. We started telling the patients, hey, don't just put it down on the sheet, but actually when you go in to the visit, say these things as well. That was a little bit better. That was a little bit better. But in all of the work we've done, we found that when a patient spontaneously reveals life context, it is used by the physician less often than when the physician asks about life context and the patient reveals the same thing. So it's more than just the patient coming up with it. Like we need to do something to get the physicians to ask if we really want the maximal kind of effect. Yeah.
Kind of a follow-up to
Yeah.
that. I was wondering if you had looked at different ways, different characteristics that the patient may find the physician in their uptake of that information. So perceived severity of some of these factors or perceived importance differing by gender, race, ethnicity, other sort of traditional social determinants.
Yeah, that's a great question. In the first unannounced standardized patient study, we had every case portrayed by both a white and a black actor. So we were interested in looking at race. We did not find a difference. But I don't think that means that there necessarily isn't a difference out there to find. And in fact, we're proposing, we haven't got a grant for it yet, but one of the things that we'd like to do in the future, working with a society that's interested in patient activation, is to ask some questions like, okay, we believe that if the patient is more assertive, if they say to the physician, is that the only thing it could be, what else can you think of, and so on. There's research that suggests that physicians do better when patients are more assertive. I think that will be highly racially bound. And probably gender too. We rarely manipulate gender because the cases tend to be gender specific. Like there are certain things that we can't do with men and can't do with women case-wise, but there are certainly some in common. Yeah. So another aside is from another project. So one case where we have seen that very strongly, the VA asked us to test their services for homeless veterans. These aren't necessarily healthcare services. These are just, can you get a meal, can you get housing, and so on. The homelessness has become very important to the VA, and they have these centers all around the country. So we've been sending actors to those centers portraying homeless veterans trying to get services, and often getting denied, and very often getting denied when the homeless veteran is not a white person, and less often getting denied when the homeless veteran is a white woman. So we do see that certainly in some healthcare kind of service settings. We haven't found it in a way that is sort of we can reliably, predictably talk about in our data yet, but it's a big question because I'm sure it's out there. The other way, as I mentioned earlier, the other way you can't find contextual error is through looking at traditional measures of patient-centered communication. And I've already alluded to this, that the physician who gets it right is not going to look like the physician who is a patient-centered communicator necessarily. So there are several different measures of sort of patient-centered communication. We took all of our transcripts and sent them to Deborah Roeder at Johns Hopkins, who's published one of the best-known of these measures, the Roeder Interaction Analysis System, which is, looks at things like how often does the clinician ask an open-ended question? How often does the patient get to speak as opposed to the clinician? How directive is the clinician? Things like that. And the measures associated with patient-centeredness, or what you might think of as, kind of niceness in a physician, totally unrelated to success in either probing for contextual factors or planning contextual. But sometimes what you really need is to ask a closed-ended question, right? As long as the physician asks the question. Okay. That's all with actors, right? The next question, of course, is does it actually happen in the real world, right? I'm a tricky psychologist. I can make all kinds of things happen in the lab or even in the field if I can manipulate everything the way I want it. That's what we do. What happens if we put hidden recorders on real patients, they're real doctors, right? Which is what we've been doing now for 5 years in the VA healthcare system. Originally as a research project, now it's been institutionalized as a quality improvement measure. So it's going on, we're testing its implementation as a QI measure at 6 VAs around the country. But as a QI project, it's like washing your hands. There's no longer an informed consent process, which is important because it means that physicians can't opt out of being studied. Right? You can't opt out of washing protocol, right? We say this is quality improvement, care quality, you don't let people opt out of that. Similarly, we want to make sure that we're not just studying the physicians who care enough to be studied. In any case, that meant we had to develop a way to figure out when a contextual error is being made, but we don't know what the right answer to the care is, right? Because it's all comers. Patients are just coming in. So we developed this coding system where we have coders who listen to these actual encounters and say, do I hear something, a red flag that seems like there might be some life context going on? Or do I see something in the chart like all of a sudden they're missing appointments, all of a sudden their sugar is high, that suggests that there could be a contextual factor. Then do we hear the physician do anything really but ask about it? Say, so why are you missing appointments? Or what's happened to your sugars? Or, you know, are you having any trouble taking your medication? Right? Whatever it is. If the physician asks about it, the patient says, no, everything's fine, great. The physician asks about it and the patient reveals a contextual factor, something's going on. I just started working as a truck driver and I drive at night and my insulin freezes in the truck. That's a real story. Then we can ask, does the physician do something about it? And do they hear that in the recording? Or do they see that in the note if we're looking at notes afterwards? So these were the results of when we first started doing this. This was about 600 recordings of patients in the VA. About a third of them, we didn't hear anything that sounded like a contextual red flag. In the other 2/3, you can see the little red people there are, we heard a flag and the physician didn't ask about it. And little green people are, we heard a flag and the physician did ask about it. So that's about a 2-to-1 ratio in favor of physician didn't ask about it. That's a problem. So then we listened to see if they dealt with the plan, if the plan was contextualized. We had 157 visits in that study where there was a contextual factor identified in the visit, right? And so we could code whether they did something, whether they planned for it or didn't. And then we followed those patients up. 9 months later, we had a different set of coders come in and ask whether they got better. Like the thing that they presented with, had it resolved by 9 months later, or was it still an ongoing problem? And what you can see here is that when the plan was contextualized at that initial visit, they were much more likely to have had their problem resolved by 9 months, about 72% of the time, than when the plan did not incorporate the revealed context. So this is our way of saying, this is not just a cute psychologist parlor trick. This actually matters in the real world. People are getting better when their physician is paying attention. Yeah.
Were these all contextual factors that a healthcare practitioner could conceivably help? Because we're keeping domestic issues perhaps where they couldn't or other issues.
So that's a great question. We like to think that if our coders who are not healthcare professionals can come up with a way that something could have been done, that another human being could have referred, for example, that we count a referral as planning, then the physician should have. So that's our proxy physician is somebody like me who's not medical. Yeah.
Alan, are these unique providers that were assessed in these contextual visits, or are they 157 unique providers?
No, there's clustering, and we use mixed models to take that out of the
And then do you account for physician quality when you make this comparison? Right? Because you could imagine that physicians who identify contextual problems are better at delivering higher quality care, and so they would resolve these problems without identifying contextual issues.
Yeah, that's possible, right? So it could be that we have the causation wrong, right? That we're just finding who are better physicians and who aren't, right? So I suppose that's a possible interpretation. Although you do have the same physicians actually in both bars in some cases. So sometimes the same physician will contextualize one patient and not another, and the physician effect in this is not large. It's really the visit effect that makes a difference. All right, so I'll wrap up with a couple of thoughts about, well, what do we do about this, right? Yeah.
Sorry, back to the last slide. If you have the same physician in both cohorts, look at why they were and weren't contextualizing the situation.
Yes, I wasn't going to cover that. Yeah. it's really hard to, that's been really hard to figure out. So there are some things that we think pretty clearly are associated with failure to contextualize. One of them is the sound of typing into the computer in the audio recording. So if the physician is trying to talk and type at the same time, they tend to do worse. And if any of you have been to a doctor in the last 5 years, you've probably had your doctor going like this and maybe they're looking this way. It's all called the doctor-computer relationship. That's clearly a problem, right? There's a multitasking overloading problem associated with trying to have physicians type and chart at the same time. And there are people who are working on that problem. There's an open charting movement, there's scribes, there's all kinds of things to try to work on that problem. Another thing that seems to predict failure to contextualize is, and this won't surprise anybody, a rigid adherence to a checklist in the exam. So as many students are trained, like these are the things you need to do in a history and a physical, and you go through your checklist and you do the review of systems and you ask about this, and you ask about that, and so on. If the physician is more interested in completing that checklist than in stopping when he or she hears something a little off and exploring that at that moment, that tends to be predictive of not getting it right. So those are two that we know about. But there's a lot of noise in this, and I think it's an open area there. There's a question with that.
Oh, I was just wondering, is there a way to deal with this more system sort of approach rather than thinking about a physician sometimes do, sometimes don't? Like, are there like ways to change systems so that everybody will consistently do what I don't know, that's best for patients?
Well, one thing that we have tried in some contexts that seem to have some effect are big posters that say, ask patients why. That helps. If people are reminded, I mean, it's a system intervention, but on the individual physician. We haven't tested it, but I do think things like scribes, where someone else is taking is filling out the chart while the physician is concentrating on the patient, ought to be helpful. I don't know that for sure, but that's a system intervention. It's a resource-intensive system intervention, but system intervention that ought to be helpful here by allowing the physician to do what they're supposed to do, which is pay attention. Yes.
Have you looked at the impact of physician specialty and then also training, such as, let's say, resident fellow versus attending, and then years in practice as well?
Okay, so I'm about to talk about the training part. Specialty, not so much, in part because all of and this is maybe the biggest limitation of all the work we've done. Nearly all of the work we've done has involved first visits by adults to primary care practitioners. So it's internal medicine and family medicine, and we haven't seen a big difference between those two, but mostly internal medicine, and it's really hard to do child actors, for example, or do pediatrics. It's really hard to have an actor, be pregnant, things like that. So, and going beyond first visit is hard for resource reasons, right? Like if you send an actor the first time and the physician says, all right, well, let's get a bunch of blood tests, and you're going to send them back. If they haven't gotten the blood test, that's weird, right? The physician's going to worry, why didn't they get the blood test? If they have gotten the blood test, you've just given a bunch of people unnecessary tests. So it's all been first visits. We've just begun to actually talk about whether we might want to try to do more longitudinal things. Because some people say, well, the fix for this is longitudinal care. Like my doctor really knows me because I've been going over time and so on. I don't think that's actually true, that's the fix. We could test some of that in our existing data by looking at relationships length of relationships between doctors and patients, but because a lot of the work we're doing now is in the VA, continuity of care is not great. We see a lot of resident change. I do want to address the training thing at the next slide, which I will do. Yes, there and there.
Have you looked at, I guess it may not apply in the VA, but have you looked at the effect of productivity standards on physician sensitivity to contextual factors. Some practices have pretty strict standards. You want to see X number of patients every Y minutes. And if you allow more time, you allow more opportunity.
Great question.
Most of the primary care docs I talk to feel that they're punching the clock.
That's right. And this is always the the question that comes up in physician audiences is, oh my gosh, how do we ever have time to do any of this stuff? So I agree, time is a problem, and more time is helpful, would be helpful. I will point out that in our study with unannounced standardized patients, the physicians who did get the cases right, who asked questions, contextualized the care, and so forth, didn't spend any more time on average than the physicians who didn't. All the visits were booked for 30 minutes. It wasn't like anybody needed more than that to do it. So we don't think it's just time.
30 minutes is a long time.
30 minutes,
primary care.
30 minutes is a typical first visit, but it is a long time for a standard visit. We have since done studies where the amount of time has varied that the visit is scheduled for. And the funny thing is what you see is 30-minute visits being conducted in 17 minutes. So that's the productivity thing, and that's part of the problem that I think you're talking about is if what you're being pushed to do is see many, many, many patients, of course you're going to try to squeeze it down and you're going to try to do only what's minimally necessary. Our argument is this is what's minimally necessary. The other kind of quality metrics, how many of your diabetic patients got foot exams this year are all chart-based. And as I mentioned earlier, that's a whole other problem, right? Another reason why you might not necessarily want to leave the chart. Yes? Oh, okay.
My question was about that hospital deferred.
All right. Nice. One more. Yeah.
So, a lot of what you're doing is looking at whether or not physicians follow up when a contextual issue arises. But have you, with these patient interviews, the real patient interviews that you have, this where it's not an actor, have you looked at whether or not more patient-centered approaches to care uncovers more contextual issues? Because I would imagine open-ended questions and allowing the patient to speak more would be more likely to uncover contextual issues. And then whether they're addressed or not,
Right.
doesn't require open-ended questions. It requires.
We didn't find that with the actors. Yeah, we didn't send all the transcripts from the real patients. So that's an open question when it comes to real patients. That could be. One of the things that we're hoping to do soon, we're writing a grant for it now, is these days a lot of people would like to record their visits, right? Not just actors with hidden recorders. Physicians really ought to assume that patients have an iPhone with a recorder on like all the time. But what if we made that explicit and visible? What if for some visits the physician knows that the visit is being recorded and the patient's going to get a copy of the audio afterwards, right? Because that's good for you. You can go back and listen to what your doctor said and remember it and so on. Would that make a difference if they knew that this was going on? Anecdotally, in the VA, we don't think so because sometimes the veterans in the VA will go in with their hidden recorder to the doctor's office, and they'll take out the recorder and put it on the table and say, ha ha ha, they told me to spy on you. And the doc will say, yeah, I know it's a project, just don't worry about it, put that away. We know this, we should hear it. And we haven't seen any difference in skill among the physicians who know they're being recorded. Those who don't, but maybe if you did it in a more systematic way. All right, let me wrap up real briefly by talking about what do we do about this. I'm in medical education. I would like to teach people to get better at this. We tried that. We did a bunch of studies where we trained medical students all about contextualization, and then we tested them using the same cases we had sent, the same actors, the same cases we had sent out to the physicians, and indeed we were able to make medical students better when they were seeing these patients in a kind of exam lab setting, to make them much better at contextualizing than the students who we hadn't trained. So we did a little randomized controlled trial with students and so on. We did the same thing with residents, and again, when the residents were in the lab, we were able to make them better. The moment we were looking at the residents taking care of real patients, no effect, right? And when we compare how well the students do to how well the the students who saw them in the lab and how well attendings did when they were seeing them actually out in their offices, the students are outperforming the attendings. And we do not believe that's because the students are better doctors. Right? Even the students who were not trained are outperforming the attendings. And that's because, of course, it's easier to do better on an exam when you know you're in an exam. Right? If we have you in a lab and you're a medical student, you're super focused on what you're doing. You're thinking about everything that's going on with this patient at once. That is not the way any of us really work in real life. So, we've been thinking about more systemic approaches. So we talked a little bit earlier about quality metrics. Well, we can use these recordings to make up some quality metrics, right? We can tell physicians, how often did you probe a red flag that we heard on the audio? And we'll tell you, here are the red flags that we heard and whether you probed them or not in the last month or whatever. How often did we hear you make a contextual plan when a factor was identified? And then we can feed this information back in cycles of audit and feedback to provider teams. In this case, the VA, pharmacists, nurses, and physicians on these teams. And we see some modest improvement over time. And these are older data, but we've continued to track this. Modest improvement, particularly in the planning part of care. Probing, asking the questions, is still pretty flat, surprisingly lower than we'd like it to be. But now when they're hearing patients say things, they are starting to pick up and incorporate them into the plan of care a little more. So this is our current kind of intervention strategy. It's a pretty standard these days kind of data-based strategy. We'll just show you how you're doing all the time, and you'll eventually want to improve and so forth. But we're always looking for other approaches that might enable us to tackle this problem, because we do think that it is a problem in healthcare. We think that these kind of errors are potentially equal to the kind of errors that we're all worried about all the time, misdosing and wrong side surgery and so on. There are people being harmed, and there are costs that we're not measuring from those harms in the system right now, and we would like to work to fix that.
Checklists, as you described earlier, may be harmful in this particular setting, but they have improved things in the past. What if those checklists included questions that ask about the context in which
Yeah, that was sort of what we were trying to do with the patient portal thing, because they could come in and then there would be, so they would pick up the questions, they had the domains of context. So we could actually say, if your patient identifies this domain of context, then, here's something you might want to ask. Right? So we have a project going on right now here at Loyola, and HRQ funded, to build something like that directly into the EMR. So when the patient says in the pre-screening, financial access, the physician gets an alert in the EMR when they go to that screening that says patient indicated financial access problem, and give them a suggestion for what to do about that. Like, ask patient what is their financial access problem, or recommend that look into cheaper drugs for this patient or whatever. So we're trying to build some technological things around that now, rather, because if we just gave people a checklist across the 12 domains of context, the problem with context is like infinite. What's in your life, what's in my life is so individualistic, and you could never come up with all the questions, and the physician would very quickly go, there's no way I'm asking 100 questions. Right? That's what we've already done enough time. So it's a great, I agree with you, like, the systematicity of it is really important, but it's hard to know how to do it.
And those visits, are the patients only seeing the physician, or are they, could it be the physician thinks, the social worker will have to see patients I only have?
That's a great question. So in the VA, at least, the patients are seeing a primary provider, which could be a pharmacist. The clinical pharmacists in the VA do a lot of actual medical care. Could be a nurse, or it could be a physician. Outside the VA, you certainly do get situations where, like in private practice, the physician knows someone else's job is to do X. So, study we're doing right now in New Jersey, a bunch of our actors screen positive for depression. Right? If somebody screens something, everyone is supposed to screen everyone at every visit for depression. That's the standard of care in internal medicine. So they screen positive, and the question is, does the physician then find out about it and do something about it? And what happens in some practices is, it's not the physician who does the screen, it's the medical assistant, right? It's somebody else, and it never makes it to the physician. Or it makes it to the physician, and they don't see it, or whatever. And then you come back and say, well, you didn't do it, and they say, well, that's not what we do, they do it, and we just get it and respond to it. And usually, what Saul says, he being the physician, talking to the physician, he says, yeah, but that's your job, right? I mean, yes, somebody else can help you with this. But you're the one who's going to take care of this patient. You're the one who's going to figure out what's about depression. You're the healer here, right? Sure, use the rest of the team, but that doesn't relieve you of the final responsibility. But it's not for.
Well, there's a meet and greet that you're gonna be at 1:30, so if you want to have a 5-minute break, we can welcome anyone that wants to talk further with Alan at 1:30.
There you go.
And, you've done a marvelous job of answering these questions.